Welcome everyone, and thank you all for coming to the first ACT Health Immunisation webinar for 2023. Tonight we will be discussing influenza and its impact globally and in the ACT. I am Dr. Leonie Harcourt, the GP advisor at Capital Health Network, and also with me tonight are Professor Robert Boy, a paediatrician from Westmead Hospital, and Dr. Jordan Breed, a GP and public health registrar at ACT Health. And of course, the events team from Capital Health Network, Canal, Kate and Mathan. So first of all, we'd like to acknowledge the traditional custodians of the land we are meeting on, the Ngunnawal people. We acknowledge and respect their continuing culture and their contribution they make to the life of this city and this region. We also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. So on to the housekeeping part of tonight. All participants have been muted. Please type in any questions you have throughout the webinar in the Q&A section on your Zoom panel, and we'll try and answer them after both speakers have completed their presentations. And copies of the slides will be sent out to people who complete their evaluation survey. So you can have a look at the slides afterwards if you complete your evaluation survey. So this session has been accredited for 1.5 hours for CPD in the educational activities section for 2023. So please provide your RACGP number to Capital Health Network and also complete the survey so that we can upload the 1.5 hours for you. If you don't do that, you can of course self-report and upload the 1.5 hours yourself on your dashboard. So the first speaker tonight is Professor Robert Boy. He's a professor of paediatrics and child health at the University of Sydney and also a senior professional fellow in child and adolescent health at Westmead Hospital. From 2008 to 2019, he was the head of clinical research at the National Centre for Immunisation Research and Surveillance. He has a PhD from Oxford University on epidemiology and prevention of Haemophilus influenza type B, and has conducted extensive research into serious infections and their prevention with over 300 scientific papers and 100 on influenza. So over to you, Robert. Thanks very much.
Thanks very much. And hopefully you can see my slides and hear my voice. I just have to share screen. We can put under pressure. Here we go. My name's a Dutch name. It's pronounced Boy, spelt with 2 O's. I'm a card-carrying Australian, and I have a Dutch passport as well. Not that just let me put that on. Okay, I am a former chairperson of the Immunisation Coalition as well, and I chair their scientific committee. I've been working on influenza for about 20 years. I'm particularly interested in both the epidemiology and the prevention of influenza. So here we go. Now, I have got on my screen a block which I tried to get rid of and it hasn't gone. Okay, I've just got to put up with some material over the top of my slides and read around it. Influenza. Flu cases were said a week ago in SBS and Channel 9 News to be 100 times higher this year than a year ago. Well, that's not quite the full story, because a year ago we were still under social distancing and we had our borders closed until the end of February. So the truth of the matter is that flu has been coming back ever since March last year, and it actually kicked off very quickly 2 months early in May last year, peaking in June instead of August. What is influenza? It's a respiratory viral disease caused by an RNA virus, and like COVID, it easily mutates into more immune evasive forms. It can cause a wide spectrum of disease. A high proportion, of course, is asymptomatic or mild, but there's a double truth, and that is that a significant minority of people do get severe illness. In the 1918-1919 pandemic, the majority of people did have mild disease, but a lot of people had severe disease, and there was a W-shaped outcome whereby there were peaks in very young children, people in their 20s, and the elderly. So the respiratory symptoms that we're very familiar with, like a common cold, I don't need to list them, but then there can be systemic symptoms as well when disease is more severe with flu, especially in vulnerable people, the very young, the very old, the in-between with multiple medical problems, immunosuppression, pregnancy, indigenous, disabled, and so on. Progression can occur in a minority of cases to viral pneumonia, sometimes even secondary bacterial pneumonia, and both stroke and heart attack are well-known complications. In patients with an underlying comorbidity, there can be a worsening of that disease or a participation of other events as listed. So influenza comes from medieval Italian, and it means influence of the stars. It also came to mean an epidemic, as it was known in those days a few hundred years ago. It's predominantly caused by two viruses, flu A and flu B, and A is the most prominent. And they both have frequent changes, mutations in their surface proteins. Now, RNA viruses tend to lack editing, a polymerase gene to correct any mistakes in the progeny of the virus. And that's why so often the baby viruses are slightly different to the parent virus. So when you have stepwise mutation of genes coding for the two proteins on the outside of influenza, like COVID, there are spikes, and in influenza they're called hemagglutinin, which helps the virus to get into cells, and neuraminidase, which helps the virus, once it's multiplied many times, to get out of cells and infect surrounding cells, especially in the respiratory epithelium. With flu, if you happen to get two infections at once of slightly different flu viruses, you can get a mixture, a recombination, which can lead to a totally new strain, which is called a shift, and that can be the cause of outbreaks and even pandemics. I was reading today that interspecies recombination is also possible. So if you have a coronavirus infection and flu, it's possible for that to lead to swapping of genes. So the composition of flu viruses needs to be updated every year. When you're infected, and you're usually infected for a few days or a week or so, the virus is actually mutating in yourself as you're being developing and experiencing symptoms. I've been on the Australian Influenza Vaccine Selection Committee for over 10 years, and this year's vaccine is slightly different to last year's, and it's important to cover what is likely to occur this year with a new vaccine. We have surveillance around the world through global influenza surveillance in over 100 countries, but Australia is proud to have hosted for over half a century a WHO collaborating centre based in Melbourne that does marvellous work. The cartoon on the right shows the spike proteins coming out of the influenza virus, the hemagglutinin and the neuraminidase, and inside there's a protein shell and an RNA nucleus. So how does influenza spread? Well, you know, coughing, sneezing, shouting, singing, and direct contact with surfaces or with people. So hugging, kissing, and the like. And that's why hand washing and social distancing and mask wearing were all important in not only controlling COVID, but they had a massive impact on influenza. Indeed, over the 2 years of 2020 and 2021, there was a rapid diminution in influenza in Australia to record low levels. So the typical course of disease in symptomatic people is to have incubation for just 1 to 3 days, similar to COVID, and then an abrupt illness, including respiratory symptoms and systemic symptoms in the minority of malaise, myalgia, fever and chills, headache. The annual burden in Australia of influenza is quite considerable. The bottom line, as you can see at the bottom right of my slide, is that 1.5 million workdays are lost every year due to influenza, which leads to over 300,000 people seeing their GP. As a consequence, 18,000 hospitalizations on average every year, and on average 3,000 deaths, sometimes 1,000, sometimes 5,000 or 6,000, but the average is about 3,000. So it's a considerable burden and much more than the common cold. Who's at risk? Well, we all know, but there's a list: people 65 and above, Indigenous, pregnant women, the disabled young children. You know all that. Pregnancy, I want to dwell on for a minute because there's some important things to appreciate that are different to other people. Pregnancy increases the risk of both morbidity and mortality, especially towards the third trimester, when studies going back 100 years show that severe flu is especially and most common in the third trimester. We know that in pregnancy, there's suppression of immunity in order to tolerate the parasite called the baby, and that can significantly increase the risk and the rate of serious illness in pregnant women. Now, the Royal College in New Zealand and Australia of obstetrician and gynecologists, together with ATAGI, recommend routine vaccination of pregnant women against flu in every pregnancy. And indeed, if you have your first dose in 2022 towards the end and you're still pregnant now and vaccine becomes available, you are recommended to have a second dose of flu vaccine in the same pregnancy because it's a new year and a new vaccine. And importantly, pregnant women not only get protection themselves, but they develop antibodies that pass across the placenta to the unborn child, and that child is then born with those antibodies and is provided protection for the first few months of life before they can be vaccinated themselves from the age of 6 months. ATAGI has released some recent advice just in the last few weeks, and in pregnancy in particular, they make the rather obvious statement that flu vaccine can be safely given. Well, until 10 years ago, that wasn't the case. And it became a WHO priority about 5 years ago to get pregnant women vaccinated against flu. But it can also be given to pregnant women at the same time as a whooping cough vaccine and a COVID-19 vaccine. The second point I've said already, I'll let you read it. And the third point is that for women who receive flu vaccine before becoming pregnant, revaccination is also recommended during pregnancy to maximize the mother's protection and the infant. So when to administer flu vaccines? Well, you know you need to have at least 10 to 14 days to develop an immune response, even if it's a booster. So that's the first point. The second is to get vaccinated before you get exposed to disease. Again, pretty obvious. So before the season is wise in April or May. Now, in 2022, I've said already that we had a big tick off in May with a surge and a peak by early June. So if we do the same again this year, it's really important to get as many people vaccinated in April and early May as possible. Now, I've given 2022 as an example. There's been many other years where the flu season has kicked off early. It usually kicks off in June, July, and peaks in August, but it can begin early. Bit of history. In 1942, Sir Macfarlane Burnet was head of the WEHI, a lab in Melbourne, and he was developing a flu vaccine as a priority for the Second World War. And he got a vaccine, developed a attenuated influenza vaccine, which became available towards the end of May 1942. Unfortunately, the flu season had already kicked off, and so he was unable to do the trial that he wanted to do. So it illustrates whether it's 80 years ago or last year, the flu season can kick off early. Pregnant women and residents of North Australia are especially recommended to get early vaccination. The duration of protection for elderly people, residents of nursing homes, tends to be shorter. They're immunosenescent. They've got an old, worn-out immune system, and perhaps only 3 to 6 months. So ATAGI says be wary not to vaccinate them too soon, but also not too late. Dedicated clinics are usually available in residential aged care facilities from April. Some people who miss the pre-season vaccination window, it's important to still offer vaccine later in the season while you have a vaccine that is effective and well tolerated. So the annual deaths from flu, as I've said already, can vary quite markedly, and they varied a lot during COVID. back in 2009, the notified number was a bit over 800 to the National Notifiable Disease Surveillance System. Now that is a underrepresentation. They used to report less than 100 back in the teenies between 2010 and 2015. So we've got better and better at reporting deaths due to influenza. The median age of deaths in almost every year is 85 or above. So most deaths, or half of deaths, are 85 and above, and half are under 85, but a good chunk of those under 85 are between 65 and 85. In 2020, with the shutdown of travel, the border closure, and the social distancing and the isolation and quarantine and all the other social distancing measures, we had only 37 flu deaths reported in Australia, an extraordinarily low number and the lowest rate in decades. By 2022, the numbers came up once the borders opened in February, March of 2022, and the flu season kicked in, and we had over 300 deaths, but there were 15,000 COVID deaths, quite a contrast. Now, this year will be, I think, dramatically different. Probably more flu deaths and probably quite a lot fewer COVID deaths as the pandemic seems to be petering out. Don't take my word for it. The numbers are going down, and the peaks of the different, the progressive peaks from Omicron have got smaller and smaller. So looking at influenza during 2022 in general practice, the surveillance showed a stark difference. The 5-year average shows that peak that I mentioned in August, but 2022 had a peak in May, late May, early June. The previous times we had big years of influenza were in both 2017 and 2019. And what was the explanation for the flu activity during 2022? And why did it begin early? Well, I've said already that there was already an early start in the Northern Hemisphere, and we'd opened up our border. So activity levels of flu were higher than average across all systems of surveillance, but it was a shorter shorter season, excuse me. The severity was moderate for 2022. The most commonly age at which cases were reported were children 5 to 9, but it was also common in kids under 5 as well. Less than 40% of children were vaccinated in 2022. Disappointing, because we had been getting up to 50% and above. Vaccine effectiveness was, as it often is, about a half, calculated as 44%, and that was against A disease because we got virtually no flu B in 2022. There was some circulation at the same time of both SARS-CoV-2 and influenza. So there were some people, a small number, who were co-infected. You could say they had flurona. There was no evidence of any neuraminidase inhibitor resistance in the viral strains that we found, influenza A, and therefore oseltamivir and zanamivir were likely to be effective, provided they were given early within 2 days of exposure of symptom onset. So here again, we see the slide I showed earlier, but I've added in some notes on the right, because not only was flu during COVID years reduced, but there was also a suppression of serious secondary bacterial diseases like pneumococcal pneumonia, like meningococcal. Indeed, as we had record low numbers of flu, we've also had record low numbers of meningococcal in 2020 and 2021, less than 100 cases per year for the first time in Australia. Normally we have 200-300 cases. And streptococcal group A disease was also reduced, and you will have seen press reports quite recently over December, January, February of increases across the country and in Europe as well of group A strep invasive infections. And some of the other respiratory viruses were reduced, but some were less suppressed and had a change in their seasonality. So there was an RSV outbreak, not at the typical time, for example. So how often to vaccinate? Well, ATAGI says annually, as I've said myself, and as everyone else says too. The virus is always changing through mutation. Antibody levels induced by vaccination sadly last only between 3 and 12 months. So for optimal protection, you need yearly vaccination. Now, currently for COVID, as you well know, if you haven't had a vaccine or disease in the last 6 months, and particularly if you're vulnerable, if you're older, or you have multiple medical problems, immunosuppression, it's a good idea to get a booster if you've gone more than 6 months since boosting or disease against COVID. So the low number of influenza infections over 2020-21 especially means that the level in the community of immunity to flu is lower. And it also makes it harder to produce the right vaccine because you've got fewer strains to choose from as to which is the most serious strain that you need to prevent. So I like to say that the impact of the COVID-19 pandemic measures was not only isolation for years, but then boom, a release and mixing and a rise in many viral and bacterial diseases over the last year. You know that public health officials and government asked people to wear masks, etc., to keep children out of schools on occasions and reduce exposure in public transport through either not using it or wearing a mask. Now, those actions did slow the spread of COVID-19 and also reduce the spread of infections like flu and bacterial secondary complications, some of which are due to, as in meningococcal, close human contact, and sometimes carriage can be conveyed through coughing and prior flu infection. As a consequence, there's reduced immunity to flu and other diseases in the community, and the seasonality was also disrupted. A WHO report from last year said that very few of the respiratory swab specimens that were tested from people around the world between September 20 and January 22 were positive for flu. So it was a worldwide phenomenon. In contrast, the average during the same period for the 3 previous years, 2017 to 20, was 17%. So flu was normally a seasonal and common infection. This was beneficial for a time, but the lack of flu, as I've said already, may well have stored up a bigger problem for 2023. Flu could possibly strike back in the coming months with a vengeance. The outbreaks in 2023, the outbreaks this year in 2023, when they start, may well be earlier, as I've said they were for 2022, and particularly because people have been flying back from the Northern Hemisphere in December, January, February, with flu seeding the local environment. And it may affect more people. How likely are we to have a big season, and how might it be avoided? Well, I think you can guess some of the answers. Winter is coming, and when winter comes, viruses spread more easily through mixing of children and adults and the elderly. But there are 3 possible reasons why the coming flu season could be worse. We've not had as good flu vaccine uptake last year and the year before. So few influenza viral samples were collected due to there being so little disease. It's possible that a threatening flu variant could have gone undetected and beginning to rise now, and our vaccine hasn't covered it. Thirdly, fewer people have been exposed to circulating flu in the past couple of years, so the levels of natural immunity will be lower. So ATAGI produced earlier this month an overview, which is good to look at the key points. Annual vaccination is the most important measure, we've said that. It's recommended for anyone from the age of 6 months. It's really important now that we use the Australian Immunisation Register because it helps us to improve uptake. All vaccinations should be recorded on it, whether done by a nurse, a pharmacist, or a GP. Last year, there was a resurgence of flu circulation when the international borders reopened. I've said that. This year, we expect seasonal activity to continue. That's a bit blasé. I expect it to be at least a moderate season. Influenza vaccines, importantly, can be co-administered, as I've said already, with any COVID-19 vaccine, but also, say, in a pregnant woman with whooping cough vaccination too, as I've said previously. So this is what has been produced by ATAGI, a table which says which vaccines are going to be available, which are going to be funded, and for what ages. So if we start with the first two columns, we can see that Vaxigrip and Fluarix are both available and can be used at any age. But if you look at people over 65, you should look to the two columns on the far right for the enhanced vaccines, Fluad Quad, which is both recommended and funded for 65 plus, and Fluzone High Dose, which is recommended but not funded this year for people 60 and above. So there's a gap group called age 60 to 64 years who can have Fluzone if they pay for it through their GP. Now, in the middle 4 rows, we see other vaccines that are also available, including Fluquadri and Influvac, which are both available at most ages. Flucelvax is new. It's available from the age of 2 years and above. It's cell-based, and it's important because not being grown in eggs like other vaccines, there's the possibility of it being a better match for the WHO strains that we've chosen to put, the vaccine strains we've chosen to put in this year's vaccine. The research on this suggests that the immunogenicity may be better. The real-world evidence shows evidence of benefit in some years from the use of this vaccine in the United States. So what's in the vaccine? Well, we can be proud to say that in most years, there's at least one vaccine virus variant that comes from Australia. And as we're using A Sydney 2021, which is an update. We're using A Darwin H3N2 in both egg-based and cell-based vaccines. I remember the year about 10 years ago when we only had a trivalent vaccine, and all 3 components, A, H1, A, H3, and B, were all Brisbane strains. So Australia does punch well above its weight. It's because Melbourne has that WHO collaborating centre, which helps to characterise strains and explore the epidemiology and the virology of strains on a regular daily basis, which are supplied from all over Australia and indeed from the Pacific to the Melbourne WHO Flu Collaborating Centre. So one more set of updates from ATAGI. I've said already that if you're 65 and above, an enhanced vaccine, whether it's adjuvanted or high dose, is preferentially recommended over standard flu vaccine. But ATAGI makes no preference statement for use of Fluad or Fluzone. And if you go to the last point, if a person had a flu influenza vaccine late in 2022 or early this year, they are still recommended to receive the new 2023 formulation, which is only coming out this month. The official story is April, but Chemist Warehouse, as usual, tried to get ahead of the game and purchase private stock that they're selling at $20 a dose in competition with primary care. Flucelvax Quad, as I've said already, is cell-based. That means it's grown in a mammalian, a dog cell, and what comes out looks very much like what gets put in. Whereas if you grow it in eggs from chickens, there's some adaptations that occur genetically to allow the virus to grow in eggs. Flucelvax Quad is not NIP funded, and you can read the rest. Both Fluad and Fluzone are preferred, I've said already. If you go to the last point, the third point, the safety of giving vaccines together at the same time, if they're adjuvanted like Fluad Quad or Shingrix, has not been formally studied. So although it's acceptable to co-administer these vaccines in separate arms on the same day, if necessary, it's best to separate by a few days. Because they're both adjuvanted, they both tickle the immune system a bit more strongly. They're both independently more likely to give a local reaction at the injection site, and also more likely to give a systemic reaction like high fever, malaise, headache. So that's why they're generally recommended to be administered separated by a few days. ATAGI's note on the timing of vaccination. We're coming hopefully towards the end of COVID, and it just might be that this year we see more flu than COVID. We don't know. People who are planning international travel should ensure they've had a 2023 influenza vaccination before departure if they can. I'm going to a conference in late April, so I intend to be vaccinated against flu before I go. Protection from flu vaccination lasts most of the year, but the highest occurs in the first 3 to 4 months. Vaccination should continue to be offered as long as there is influenza viruses circulating in the community, and valid vaccines these days don't expire often until February of the following year, so they last for almost a year in terms of their safety and their effectiveness. Now, I mentioned Flucelvax. This is an illustration just to say that the human influenza virus sometimes doesn't grow so well in eggs, and it can even be pathogenic to eggs, and that the virus adapts to the hostile environment of growing, or not hostile, but challenging environment of growing into an egg, and it may therefore growing in an egg, and it may therefore acquire mutations which make it different to the parent strain, and that could impact on vaccine effectiveness. A few more special points before I draw to a close. Flu and COVID vaccines, I've said already, can be given at the same time, but not yet in one injection. Both Novavax and Moderna and other companies are in the throes of developing 2-in-1 and 3-in-1 vaccines to cover COVID, flu, and RSV ultimately. Such vaccines, trying to protect against both flu and COVID is especially important in at-risk populations, those that are immunosuppressed or elderly immunosenescent. There's a new thing to note, that when you're routinely vaccinating children at 6 months of age against 6-in-1 DTP, Hep B, Hib, and polio, consider, and you're recommended to give concomitant flu vaccination. The first flu jab comes in at 6 months of age. This has been a suggestion of the Immunisation Coalition and other bodies, and it's now a recommendation from ATAGI. Said already that it's important to use the Australian Immunisation Register to record uptake, but also to identify both adults and children who are unvaccinated, and to implement reminder systems and recall so that you can catch up on the people who missed out in the second month of availability. Get the bulk of people done in the first month, and then do reminder and recall for those that have missed out. There are now conversations that can be helped by healthcare workers about child vaccination. They're available on a website, sky.org.au, which is short for Sharing Knowledge About Immunisation. So that knowledge can be shared from the website through you as a healthcare worker to parents. And the healthcare workers are really the most influential reason why parents decide to get their children vaccinated. For parents themselves, there's a website for them to look out, all one word, talkingaboutimmunisation.org.au, a very helpful and strongly recommended website in the CMO's letter. And just for your interest, A survey I just saw last week from the Royal Children's Hospital in Melbourne suggests that 1/3 of parents don't know that flu can be serious in kids. So there's a real need for better education of parents to get children vaccinated and protected against flu. Now, flu and COVID are very different in kids. Flu can be moderately to moderately severe, but COVID tends not to be. So there's all these subtle epidemiological differences between viruses, which are important to know and to understand. I said I'd cover briefly the other vaccines that are developed. I've mentioned already that mRNA companies are not only developing a flu vaccine, but a flu, COVID and RSV combined vaccine. There are other companies developing a nasal COVID vaccine, and I'm involved with a company in Australia that's working on a nanopatch, a skin-based COVID vaccine, which is currently in human studies as well. So watch this space, none of them are available yet. Chemist Warehouse, I've mentioned already. I saw a newspaper spread last week saying that they had a flu shot vaccination service using doctors, nurses, and pharmacists. It takes, as they say, a community to build immunity. And book now, because they have, I went into the store and they said they were taking bookings from the 21st of March, which is only next week, for only $20. So that's what the picture looked like, their vaccination service. Have you seen the ad? What do you think about it? I wonder how they can manage to do it for $20, but it may be a loss-leading approach to encourage people who have to wait for 15 minutes after vaccination to do some casual shopping. What do you think? So to close on a rather somber note, Australia actually recorded 20,000 excess deaths in 2022, predominantly occurring after we opened up in February, March. 10,000 are thought to be due to the COVID-19 pandemic, and another 3,000 where COVID virus infection contributed to the death. So COVID is involved in 2/3 of the excess deaths in 2022, and a great proportion, that most of them were elderly, but all age groups were affected. So the Actuaries Institute, which is the source of this information, predicted, based on yearly averages and trends, that Australia would have 172,000 deaths last year. Remember, we have about 300,000 births. The actual was 12% higher, which means that's the difference between the total number of deaths in a year and the expected number. The total number was 192,000. So I hope that as COVID recedes and as flu perhaps increases again this year, that we take measures to protect against both COVID and flu with vaccination and all the other social distancing measures being recommended still for vulnerable people who would most benefit. Thanks very much.
Thank you so much, Robert. That was really interesting. And yes, that was a bit of a somber note at the end and a very good testament for getting vaccinated and getting vaccinated at the right time. So there's already a few questions, so keep them coming. Our next speaker tonight is Dr. Jordan Breed, who is also a general practitioner and a public health registrar at ACT Health. And he's on secondment from the Australian Defence Force. He's got roles in aeromedical evaluation operations and has also been deployed in health support planning and expeditionary medicine. Very exciting. So thank you, Dr. Breed.
Thanks, Leonie. I'll just share my screen. Okay. Thanks for having me tonight. I'll be providing some complementary information, reinforcing some of what Prof. Boys included in his excellent presentation. So thanks for your time tonight. And I'll be applying the ACT lens or context to that. So tonight I'll provide an overview of influenza in the ACT, both in terms of epidemiology and vaccine rollout last year, and provide an update on our vaccine program for this year. I'll start with the epidemiology. So to complement the information provided by Prof. Boy in his presentation. This is ACT specific data. It's based on notifications of laboratory confirmed influenza cases, and it's by year and through to the start of October last year. Generally, we know that notified cases only represent a small proportion of cases occurring in the community. However, it's representative of the size and shape across years. The traditional season for influenza is shown by the green double arrow there, which is for early May to early October. And as Prof. Boy mentioned, the cases in 2022 were early, sharp, and relatively quick. Almost all of the cases were influenza A in the ACT. And you can see that this represents a return to more normal epidemiology following the lower rates whilst COVID control measures were in place. We know that making a comparison to previous years, so you can see certainly 2017, 2018 data there are big peaks, is difficult because of changes in testing behaviour over the course of the pandemic. I'd just like to take the opportunity to remind everyone that this is publicly available information. Reports on influenza regularly published on the ACT Health website. So throughout the season, take the opportunity to have a look at those for up-to-date information, what's happening in our local context. The next two slides, this one you'll recognise from Prof. Boy's presentation, are primarily for the purpose of demonstrating other surveillance systems that you can participate in. The one here is from the Australian Sentinel Practices Research Network, or ASPRN. We have 6 sites in the ACT that participate in this, and it's de-identified information on influenza-like illness presentations. The other point to note from both of these slides is that these surveillance programs match quite closely the patterns that we see in notification. This slide represents data from the flu tracking program, which was established in 2006, which is a self-reported program by members of the public. It consists of an online survey conducted weekly during the influenza season, which has been expanded in 2020 due to COVID. So that's why you'll see a difference between current reporting and the 5-year average. The solid lines are people who have reported fever and cough, and the dashed lines include additional absence from workplace or usual activities. We know that the ACT generally has high rates of reporting, and this is seen in our participation in flu tracking. So I'd encourage you, if you haven't already, to sign up and participate in this, because it provides valuable information for our service. This graph depicts the absolute number of influenza notifications and notification rate by age, and I've included this to highlight the high notification rate amongst younger children. In the ACT setting, it was equal amongst the 0 to 4 and 5 to 9 age groups, and this is important as one of the focuses of the program this year, in line with the TARGI advice and the Chief Medical Officer recommendations, is focusing on NIP funded immunisation in that 0 to 4 age group. We know that this age group is at higher risk of hospitalisation and morbidity from influenza, and it's true of all children of the age group, not just those with pre-existing medical conditions. I'll now move on to provide some context of what's happening this year based on the information from the vaccine program and delivery last year. This graph depicts the cumulative national immunisation program influenza vaccine distribution in the ACT across the last 5 seasons. 2022 is depicted by the light blue line there, which is good. It confirms enduring increased demand and uptake following record demand in 2020. This table provides the immunisation rates of the ACT versus national rates by age group. It's not surprising, based on our knowledge and experience of vaccine uptake in the ACT, that our vaccine uptake for influenza is good compared to the national average. It's taken from the Australian Immunisation Register using the total number of Medicare registered persons as the denominator. It's likely to be an underrepresentation of true uptake due to underreporting of vaccine doses on the air, which reinforces the importance of reporting through the air. And we can see that uptake was best in the ACT for those under 5 and over 50 age groups, which is excellent. Aboriginal and Torres Strait Islander influenza immunisation rates in the ACT were substantially lower than the total population immunisation rate here for those under the age of 50 and fairly equivocal for those over the age of 50. Pleasingly though, again, these immunisation rates are above the national averages for Aboriginal and Torres Strait Islanders across all age groups. Similarly with young children, we know that Aboriginal and Torres Strait Islander people are at increased risk of hospitalisation and morbidity from influenza, and all Aboriginal and Torres Strait Islander people over the age of 6 months are eligible for free NIP-funded vaccines. The availability of this data also serves as an important reminder and encouragement to ensure documentation of Aboriginal and Torres Strait Islander status at each clinical encounter. The final information from the 2022 rollout here is vaccination provider type. We can see that GPs have remained the most common provider for influenza immunisation, with just over half of all vaccine administration in the ACT last year. And pharmacists are also prominent providers, administering over a quarter of all vaccines, including NIP-funded vaccines for over 65. Yeah. The other category here includes all other provider types and would include residential aged care facilities, correctional facilities, health service sites, including obstetric services, and occupational sites as well. So moving on to the influenza vaccine rollout for 2023 in the ACT. As we've already discussed, the recommendation is that all people over the age of 6 months receive an influenza vaccine every year. There's been no change to the NIP funded eligibility from last year and previous years. And I'll include the eligible medical conditions on the next slide. But this information's widely available and will be distributed, so you've got it readily at hand for your clinics. Again, no changes to comorbidity eligibility. Of note, chronic renal failure does remain eligible this year as inadvertently admitted from early online version of the ATAGI guidance, and it's since been amended to be included, and that's in all current online and print resources. We know that there are additional groups that are at risk of severe disease who aren't covered by the National Immunisation Program. So I'd encourage you to review the immunisation handbook and identify these patients and have the discussion about private vaccines. Of note, comorbidities don't include people with obesity. However, they might be eligible for a funded vaccine if they also have the presence of metabolic syndrome under the chronic metabolic disorders. This is the quick reference poster for NIP-funded vaccines that we'll be distributing this year. Of note, in the orange, the vaccines that are for the younger age groups from 6 months to under 5 years old, importantly for NIP without medical comorbidities. But those vaccines being administered for the first time, the first year for 6 months to less than 9-year-olds, the recommendation is that they'd receive 2 doses at least 4 weeks apart in that first year. And that recommendation also extends to people post hematopoietic stem cell or solid organ transplant in their first year again. So 2 doses spread at least 4 weeks apart. Just reinforcing what Prof. Boyes said, the adjuvanted influenza vaccine Fluad Quad is the preferentially recommended vaccine for those 65 years or older, given a higher immunogenicity amongst the NIP-funded influenza vaccines. I did see someone made a comment that they had a little bit of difficulty seeing the table on Prof. Boy's slide. So I do have it included here, which was fortuitous. This table is taken directly from the ATAGI guidance, so is easily accessible online. It provides a nice overview of all registered vaccines, national immunisation funding status, program funding status, and age or comorbidity eligibility. This version also includes quite clear NIP funding in the white boxes, but it does provide a fairly useful overview of what's available in the private market as well. Just highlight and reinforce that both NIP-funded and private influenza immunisations must be recorded in the Australian Immunisation Register. And in this slide, as Prof. Boy pointed out, you can also see that the Fluzone high dose quad is a private option available for those over 60 years and is equally preferentially recommended for those over 65 years of age. The ATAGI advice is that we should encourage the promotion of the free vaccine to all eligible groups. However, Chief Medical Officer and ATAGI have listed focus on improving uptake in children under the age of 5, First Nations people, and pregnant women. I'd like to reinforce what Prof. Boy shared about the sharing knowledge about immunisation. The Sky website for providers has excellent quality clinician resources to support vaccine uptake, particularly in children and pregnant women. So I commend those to you. There's also a public-facing site that you can direct your patients to. And the National Centre for Immunisation Research and Surveillance, NCIS, have also developed a support resource for discussing influenza vaccine with Aboriginal and Torres Strait Islander peoples, first page of which you can see on the right of the slide there. Again, it's an excellent resource and I commend that to you, both of which are very easy to find via a brief Google search for those terms. This was covered very well in the previous presentation, so I'll just allow that to sink in for a moment. The only thing that I would add is that pertussis immunisation may be a prompt or a reminder to check for influenza immunisation status and an opportunity to deliver that if you hadn't otherwise had the opportunity. This is unchanged from previous year's recommendations. A brief word on egg allergies. The Australasian Society of Clinical Immunology and Allergy have a statement on the delivery of influenza vaccine for those that have egg allergies. And there's no evidence that having an egg allergy increases the risk of having an allergic reaction to the currently available influenza vaccines. The immunisation handbook provides this helpful table, which reinforces that it's safe and suitable to administer these in the primary care setting, provided that the staff are experienced in recognising and treating anaphylaxis. We've had some feedback through different networks that it'd be appreciated to have some discussion on winter wellness and COVID as part of influenza vaccine rollout this year. Influenza immunisation is a great time to consider preparedness for COVID and all other respiratory viruses with your patients. COVID booster recommendations for anyone who hasn't been vaccinated or infected with COVID in the last 6 months are as per the ATAGI recommendations and are depicted in our social media graphic here. This information does evolve regularly, so I encourage you to please keep up to date with the information published online. The other thing to note is that we strongly encourage you to have discussions with your patients and continue to encourage them to exhibit COVID smart behaviours. Our public communications on social media and web content over the coming months is going to focus on preparedness for winter, and this will include encouraging the public to talk to their healthcare team before they get sick. And we want this to include the development of a plan for accessing treatment and testing for if or when the individual becomes sick. So we encourage you to have those conversations and start developing those plans with your patients now. And again, at influenza immunisation may be a suitable time to do this, depending on capacity within the clinic. Noting the end of the COVID management declaration and the closure of the Garran Surge Centre in the last month, there have been substantial recent changes to the testing availability in the ACT. RATs remain widely available commercially through retail stores and pharmacies. To support equitable access, RATs will also be available and are so available at ACT library sites and Access Canberra service centres if consumers are attending the service centre for another reason. We would appreciate it if you would encourage your patients, and we will with the general public, to have a supply, particularly of RATs, prior to developing symptoms, and to continue reporting positive results of these, because that, despite not being mandatory now, is particularly important for our ongoing surveillance. RATs are also available at Canberra Health Service facilities, including walk-in centres, where we encourage visitors to undertake a RAT before entering. Access to PCRs without a pathology form is a substantial change, and it's now only available to concession card holders. The full list of cards that are accepted are on the ACT Health COVID website. And it's anticipated that this access will facilitate prompt diagnosis and initiation of antiviral therapy for eligible patients where they're at higher risk of severe disease. So this could form part of that testing plan for a patient who would be eligible, whereby they don't need to wait to attend a clinic and get a referral for a PCR on commencement of symptoms. And of course, PCRs remain available with referral through the normal pathology services. On the right-hand side of this slide, I've just got the first page of the ACT Health pre-assessment form for antivirals, which does include a couple of pages. It's a useful tool that may assist you in developing a plan for treatment with your patients in advance of symptoms. Moving on to some practicalities, the Vaccine Management Unit aimed to distribute approximately 50,000 doses of NIP-funded influenza vaccines to an estimate of 210 providers during the beginning of April. Immunisation providers are free to commence vaccination as soon as the stock hits their fridge. And the initial stock allocations are based on historical vaccination usage by each provider. The distribution will be accompanied by an influenza resource pack, which will include promotional material, ATAGI advice, and data collection forms. It'll also include information on further ordering and supply, which will be in line with normal ACT NIP supply processes. Now would be an ideal time from a practical perspective to consider your influenza vaccination plan at your clinics and sites and to review the National Vaccine Storage Guidelines, or STRIVE for 5. Just a reminder that adverse events following immunisation, or AEFIs, are a notifiable condition in the ACT, and an AEFI is defined as any negative reaction that follows vaccination. It doesn't necessarily have a causal relationship with the vaccine, and conclusion regarding causation isn't necessary to suspect or report an AEFI. You may report these via phone, email, fax, or web form, and I would expect that the web form on the ACT Health website might be the easiest way for you to be able to do this. Here's the key take-home points, which align closely to Prof. Boys, which is great. I'll commend those to your reading, and I look forward to any questions shortly. And just finally, I've provided some useful resources. It sounds as though if you complete the post-webinar evaluation, you'll be able to get access to the presentation. So hopefully the web links will be able to work for you. and there's the immunisation unit contact details.
Thanks so much, Jordan. That was really great. Obviously, there's more we can do in terms of getting a larger number of Canberrans vaccinated, but if it was a competition, we would be winning. So go Canberra. So we've got quite a few questions on the Q&A panel, so I'll try and get through a number of them, and I'll kind of select you randomly to answer them, not so randomly. So the first question we had was possibly one for Robert, and it was just if you could comment briefly on the adenovirus outbreak in India, which has caused a number of child deaths, and whether you think that this might come to Australia.
Well, India is always very interesting. There's a little bit of a surge in COVID there at the moment as well. One of the grandsons of Omicron is surging a little bit. Last year they had the Kerala tomato flu, which actually turned out to be hand, foot and mouth disease. The adenovirus surge does happen from time to time. Adenovirus can be really quite nasty because it can affect both the respiratory and the GI tracts. And in people with abnormal immune systems, it can be especially severe. People travel to India visiting friends and relatives and bring back viruses all the time. So I can see adenoviruses incubating in people who aren't yet symptomatic on the plane and becoming symptomatic a day or two after landing, and potentially creating small chains of transmission. So it's possible. GPs need to be aware of what's traveling around the world and what's traveling around their local area. So yes, adenovirus could surge a little bit. I don't expect a big surge, but that's why we have surveillance, and that's why we collect samples, and viral labs are now able to do multiplex for 10 or a dozen viruses, and it can find adenovirus among them.
Okay, that's great. Thanks, Robert. So our next question is going to you, Jordan. So it's kind of a two-pronged question. So part one is, why can't older people who have waning immunity get a second vaccination within the same year? And then the second part of that is somebody's written in that there's quite a few over 65-year-olds who go and get a private vaccination, possibly before the NIPS, National Immunisation Program vaccinations have come out, and then come along a couple of months later to the GP saying, can they get their government-funded vaccination? Is that a go?
Thank you very much. After I provide my answer, I might invite Prof. Boyer to also comment. The current ATAGI guidance doesn't recommend vaccinating twice within the same season. However, occasionally in certain circumstances, such as outbreaks in specific settings like residential aged care, we may consider or recommend that. And just highlighting that all of the vaccinations should be recorded in the air. So hopefully, if your patients aren't being particularly forthcoming with you about their prior immunisation earlier in the season in a pharmacy setting, you'll be able to get that information and have a conversation with them about that recommendation.
Could I just clarify or split hairs? So, for example, if they'd had an afluria quad in February and they're over 65, and then they come in for their fluad in April, that's still not the go?
No, that's a good exception.
Yeah.
What you have in February is last year's vaccine, because that's runs out of time, expires by the end of February, and you don't have this year's vaccine available in February. If you're Chemist Warehouse, you might have it in March. But
so, okay, for example, if they had the afluria quad,
you need to give the appropriate vaccine, which is Fluad, which is enhanced.
Yeah, so they have maybe one in March and then another one.
The second vaccine, yeah.
So so they should get their Fluad no matter if they've had the inappropriate vaccine earlier privately.
You bet.
Yep. Okay, now another one for you, Robert. So there's a question, what can you administer with the flu vaccination? I think you covered the one about shingles, the shingles vaccination. So Shingrix and Zostavax, maybe?
So I'll give you the complicated answer. I've said already that Fluad and Shingrix, both being adjuvanted, are not a good idea to give together. So that's obvious. But when you're 70 and you're getting a Zostavax, you're getting a live attenuated vaccine. And provided you're not severely immunocompromised, you can have that and you can have Fluad on the same day, because Zostavax is not an adjuvanted vaccine. However, if you're between 50 and 69, you may or may not have had an enhanced vaccine like Fluad. Under 65, you won't. So you could have on the privately a Shingrix between 50 and 64 and a standard flu vaccine, or a Fluzone if you're 60 to 64. Getting complicated now, but
Yes.
I think you can see what I'm saying.
There's another question along co-administration, and this one was for a pregnant woman, anti-D and the flu vaccine.
Sure. So anti-D is to stop anti-D hemolytic syndrome in women, and which affects their babies. It's given it as an antibody to D antigen at 28 and 34 weeks. So the first 6 months of pregnancy, if you're eligible for a flu vaccine, you should have it before you ever get your first anti-D at 28 weeks. And for the last month of pregnancy, if you're eligible and haven't had flu vaccine, you should have it because it protects both you and your baby at vulnerable times. To the best of my knowledge, you can give anti-D and a flu vaccine at the same time. I don't know of any interference.
Thanks. Okay, now another one for you, Jordan. So there's a question is, can ACT Health develop a single form for consent for antivirals and for vaccination for COVID and influenza?
That's an excellent question. I just reiterate that we developed the form to support conversations about preparedness with patients and not necessarily to provide consent. And consent could be verbal in these instances. So it's not on the radar, but we will give due consideration to the comment.
Thanks. Okay, and another one for you, Jordan. So people wanting to get a PCR, and I'm not sure, I think this might be a flu PCR rather than a COVID PCR. Can they just turn up to ACT Pathology if they're concession card holders, or do they need to notify ACT Pathology first that they're turning up and they're sick?
So I think the concession card query would be relating to COVID. Influenza PCR always will need a pathology referral. For COVID PCRs, I'd encourage you and patients, the general public, to check the ACT website prior to attending, just to ensure that you're accessing the most up-to-date information, and it'll provide advice on which collection centres they can attend and the process for doing so. But it essentially is quite easy that they can turn up to an eligible site, and they don't need to have seen their GP on the day or have any type of on-referral.
Okay, I will just see if we have any more questions. So here is another question. And someone's asked, what is the average length of the season? Is it April to September?
Oh, Jordan's answered that, but to be precise, we don't know, because it sometimes kicks off in April and sometimes in June. Most often it kicks off in June and peaks in September and August rather, and declines in September and is gone during October. But as I said in my talk, it can kick off in late April, May, and even peak sometimes in May, early June, as it did last year and as it did 80 years ago and as it did some years in between as well.
Okay, here is another pregnancy question. So what's a reasonable time gap if a woman's was vaccinated for flu before she became pregnant, is pregnant, and now wants to become revaccinated?
You don't have to get all head up about a gap. As soon as a woman is pregnant and wants protection, she can get vaccination if it's available, and the flu season is on. So vaccine available, flu season, pregnant, get a jab.
Okay, the questions are still coming in thick and fast. So can a person whose swab is positive for influenza still have the vaccine?
I'll have a go at answering that. Remember, influenza vaccine contains 4 strains, AH3, AH1, and 2 different B strains. So you may be positive with one, but the vaccination is providing protection against 3 or 4. So I think the answer is inherent in knowing that. Something that was on my slide that I didn't verbalize is that the Yamagata lineage of B has almost disappeared in the last 2 years internationally. So much as we went 50 years ago from 1 flu A to then to 2, and then to a triple vaccine 20 years ago, and to a quadrivalent vaccine 5 years ago, there's, I guess, the possibility we'll go back to a trivalent vaccine with only 1 B if the Yamagata continues to stay away in the next couple of years. But the answer to the question is yes, once you've recovered from your flu disease, vaccination will provide protection against the other types in the vaccine.
And so related to this, and I guess kind of with the COVID, no vaccination for 6 months after COVID infection, is there any gap after being influenza positive that you can give the flu vaccine? And I think you've 50% or 60% answered that question, but if you'd like to comment on that.
I would say that once you're recovered, that usually takes a week, sometimes several weeks. As soon as that, because with COVID, we're just talking about one main strain, Omicron variants, subvariants. But with flu, we are talking about distinct differences, which is why we put 4 different strains in the vaccine. So, yeah.
Okay, possibly another one for you, Robert. So you're kind of under fire. Patients having dialysis, are they eligible for more than 1 flu vaccine? And if so, how far apart?
Yeah, if you've got renal failure, you're in the group who are moderately severely immunosuppressed. And certainly they're the kind of people you give a second flu jab to late in the season to provide longer term protection. So as a general rule, not just the specific example you give, anyone with moderate to severe immunosuppression, you should seriously consider a second dose late in the flu season before it's ended.
Okay. I'll just check with Kunal and he's giving me the nod. No more questions. I've got a question of my own, if that's okay. So if we generally say that the flu is a clinical diagnosis and we don't generally test for it, so maybe just reviewing the indications for testing it would be good. How do we come up with the annual estimates of numbers?
Yes, there's a lot of mathematical modelling as well as actual surveillance, and the two combined give us the best estimate we can come up with. We've done better and better surveillance, as I intimated, over the last 20 years. Back when I was doing studies before 2010, I often would find that the AIHW or the appropriate body was only recording 5, 10 or 15 flu deaths a year. So now we're recording hundreds. It's not that it's got more severe, we just got better at surveillance. We've got more room for improved surveillance. I think in regard to testing, you want to have an implication of of a positive test. And if you've got someone who has a major medical problem, immunosuppression, etc., or elderly, then the result of your test, if it's flu, could lead to early antiviral treatment. And that's worthwhile. We did a study 10 years ago showing the benefit of early testing, early diagnosis, and early antiviral in aged care facilities. So if there's a reason for doing the test, that's one way to choose why to do one.
Okay, thank you. Thanks for that. That's very good. So I think we've got no more questions, so we might wrap it up. So just to thank both presenters very much. Obviously, it's generated a lot of questions and a lot of interest, and we've got over 140 people watching the webinar tonight, and there might be well more watching the YouTube replay. So obviously a lot of interest in the ACT for the influenza season in 2023. Just to reiterate, Capital Health Network can upload 1.5 hours of CPD for you if you provide us with your RACGP number and complete the evaluation survey, which Canal is sending out for you tonight. So if you could return that to us as soon as possible. And we will also make the resources and slides available to you as well. And thank you very much again to our presenters. Okay, good night.